Sleep Organization. He is a credentialed diplomat of the American Board of Dental Sleep Medicine. Dr. Viviano has lectured internationally, conducted original research, and authored articles on the management of sleep-disordered breathing and the use of acoustic reflection to evaluate the upper airway. Please welcome Dr. John Viviano.
Good morning. Thank you very much for coming out this morning. I appreciate the opportunity that Innovative Insight Seminars has provided me here to speak with you. This is a subject that's very, very passionate for me. I think you'll be able to tell over the next 4 hours. It's really timely in the media right now. There's a lot of information about it. I'm sure you're having patients come in on a regular basis, maybe an overstatement, but not quite for some offices where they're asking, do you guys do anything about snoring or sleep apnea? Because they're hearing about it in the media. I mean, 10 years ago, if there was a course at the ODA or at the Winter Clinic or the Spring Clinic regarding oral appliance therapy, yeah, the room would be half full, 3/4 full. Now when there's a course, it's packed and there's line up out the door. Dentists want to learn more about this because they're being asked and they need to know about this stuff. There's a whole whack of these patients that you see on a daily basis that are not sleeping well and that are having these issues that you can help direct towards the area they should be concentrating on, because they don't know this is available to them. Sure, there's the ones that are hearing about it in the media that maybe the wife is nudging the husband, hey, that's you, or vice versa, but there's a lot of people that they still don't catch on. And a lot of the reason is because they're walking around in a fog. They're not even comprehending. They don't get it that applies to them. They think something else is wrong. And they don't realize, well, their airway is actually physically closing down several times an hour, 25 times an hour, 60 times an hour, and this is interrupting their sleep. And there's a remedy for it. And dentistry has one of the remedies, and it's actually one of the preferred remedies as far as patients are concerned. And you'll learn all about that today. I have no affiliations with any company, any appliance, any ambulatory sleep screen, or any device. Okay, I'm just a wet finger dentist in Mississauga that always gets a thrill when a company calls them because they want to come and talk to them. But I have there's no money exchange or no, I don't have no allegiances. When you are managing sleep apnea, you're managing a medical disorder. This is not dentistry. So the rules change, it's a different game altogether. Your responsibilities change, and you have to accept side effects and issues that are much less important than the issue you're correcting, right? Compared to when we're doing dentistry, do no harm, no iatrogenic dentistry. You have to go in stealthily, do what you have to do, and get out of there doing no harm, leaving the patient better off in every way. This is what's ingrained into us. Now when we put appliances in that actually cause tooth movement, and people start getting all nervous, oh my God, we're ruining people's teeth. Things that we're trying to preserve and protect. That's what we've made an oath to do. But, nobody's ever died of a malocclusion. But people do die from obstructive sleep apnea. And so we have to go through a real paradigm shift in considering what we're doing. So, what is sleep disorders dentistry? Basically, it's management of the airway and sleep bruxism. So it's management of malfunction of breathing during sleep. You stop breathing, and now with a jolt, you wake up, and you start breathing again. At the end of the day, what we're talking about is an appliance in the mouth versus a mask on the face. We're going to be talking about other treatment options. But at the end of the day, these are the two most conservative and the ones that have the highest success rate. So if we want to just dismiss everything else for the moment, this is really what we're talking about. Never convert somebody from a CPAP if they love it, if they're compliant, if they're 100% compliant. You don't mess with that. But if they're not compliant, which is a good number of these patients, you don't talk to them about oral appliances. This is what you're okay with. You're okay leaving them like that when you could offer them the other. Okay? That's really what it's all about at the end of the day. So, snoring. Who in this room hasn't heard snoring? What it is basically is rattling around of the soft tissue. Rattling around of all the loose soft tissue in there. It could be back of the tongue. It could be the soft palate. It could be the uvula. It could be the tonsillar pillars. You know, anything that's loose, rattling around, you have a musical instrument in your throat. And it's usually on inspiration. There's occasional snores. What you'll find is that people don't snore unless they drink. So if the night before they had 4 or 5 beers or 3 or 4 martinis, that night they'll snore. Okay. You find the habitual snores. Those the ones that are chronic snoring every night, and then the ones that maybe snore maybe 2 or 3 nights a week. Okay. Then at the end of the day, it's either simple snoring with no real other implications or side effects aside from bothering a sleep partner, and there's pathological snoring, where there's other issues. They wake up tired. You know, there's other things going on. You got this real sore throat in the morning. The mouth is all dry. One thing that's very critical that we've only been talking about in the last few years is the impact on the bed partner's sleep. What we've always focused on before is the fact that it bothered the bed partner. It's just bothersome to the bed partner. But in fact, there's much more to it than that, and it actually does impact on their quality of sleep and indirectly then their health. So elimination of the snoring and apnea improves both people's sleep. Okay. Spectrum of disease is related to the airway size. So this size, this is a cross-section of the airway, right? That's another view of the airway. So you can see the flow of air. No obstruction. This is normal. We just talked about the airway narrowing in size. Get a little bit of flow limitation. The airway is a little bit narrower now. Air still gets through, but not as much. And it takes more effort to pull that air through. Next, you got obstructive apnea. The airway narrows down. Hypopnea, I should say. The airway narrows down. Okay? Even more restricted. And then you get straight out obstructive apnea where the airway actually closes down and stops any air from going through. So this is the spectrum of disease from just simple snoring and normal breathing to upper airway resistance syndrome to some level of obstructive sleep apnea, which includes both hypopneas and apneas. On the spectrum of easier to treat, RERAs, where you don't get closing down completely at all, you just get a little narrowing, is the easiest to treat. No, snoring is the easiest to treat. You just get rattling around the soft tissue. RERAs are the second easiest to treat. As we go on the progression of severity of disease, it becomes more difficult. Then hypopneas are a little harder to treat, and obstructive are the most hard to treat when the airways close down completely. So snoring versus apnea. Snorers may or may not have apnea. 6% of snorers have apnea, of which 80% are undiagnosed. So if you wonder about whether there's patients that you should be speaking to in your practice on a daily basis, think about these statistics. Okay? 95% of people affected with apnea snore. So almost everybody that has apnea snores, but not everybody. So you're going to come across those patients that have lousy sleep and are complaining about feeling tired and waking feeling tired, but there's no evidence of any snoring at all. Obviously the minority, but that does exist, so don't let that throw you off. So daytime symptoms, excessive daytime sleepiness, they feel tired. Everything we talked about earlier, you know, if you wake up after having like too much fun the night before, that hangover feeling, you know, would pertain to this. Poor concentration and performance, poor memory, clouded intellect, non-restorative sleep, fatigue, morning headache, personality changes, grumpy, short-tempered, depression, irritability, decreased sex drive, impotence, auto and work-related accidents. These are the daytime symptoms associated with snoring and OSA. Nighttime symptoms, awakening with gasping or choking, just like you saw in that video. Frequent awakening or going to the bathroom through the sleep period 3, 4, 5, 6 times. Snoring in the bathroom, not in your bed. Just waking up to go to the bathroom. Snoring, intermittent pauses. So they're snoring, snoring, snoring. There's silence, a little gasp. They have their apnea, and they start snoring again. That's basically the cardinal sign of sleep apnea. Thrashing in bed, restless sleep. These people are tossing and turning all night long. They never get down into that deep sleep or don't spend much time at all in that deep sleep where their sleep is nice and consolidated and peaceful. Hypertension, especially hypertension that is not responsive to medication. So if you're talking to a patient about their hypertension and the doctor's changing them from this to this to this, trying to find a medication that will take care of their problem, they may in fact have sleep apnea. And they can try 15 different drugs, and it's just not going to take care of the problem. But once they take care of that sleep apnea, their blood pressure will normalize. Now, you'd think that the physician would be on top of that, but you cannot assume that. You cannot assume that that physician has reviewed with them whether they have sleep apnea or investigated that. So don't feel foolish, oh, they should know what they're talking about. I'm only a hygienist or I'm only a dentist. I shouldn't interfere in this. No, don't make this assumption.